Good afternoon guys, and welcome to the final installment of the Rotation Diaries. If this is the first video you're watching of mine, hey, welcome. My name is Kris. I'm a GP registrar from Australia, and I've been doing a series recounting all the rotations I did as a junior officer here in Queensland. This, like I said, is the last one, and it is my psychiatry rotation. If you're interested, stay tuned, but don't forget to give me a like, subscribe, and leave a comment. What do you want from me next? This is it. I've done this big series that took quite a fair bit of work, more than I anticipated. So, let me know what you want from me. Alrighty guys, let's get into it. So I did my psychiatry rotation at the end of 2018 and into January of 2019. As with all of my other rotations, I did this in a relatively small regional town here in Queensland, and we didn't have any specific wards for psychiatry, as in no subspecialty wards. In our psychiatry ward, we had about 30 beds or 30 rooms, and we also had a 5 to 7 bed psychiatric intensive care unit, where we would put people who were more volatile, violent, or required real one-on-one care, at least until they could be discharged into the lower acuity general psychiatry ward. In the rotation, I dealt with patients with all sorts of mental health issues, from depression, anxiety, situational crises, schizophrenia, bipolar disorder, anorexia nervosa, bulimia nervosa, so much. It was quite a mixed bag. We were often what we call bed blocked, basically meaning that we were at full capacity. So we always had about the 30 to 40 patients in the unit. Because of the number of staff we had, we were able to split the ward into 2 teams, Team 1 and Team 2. Basically, we did it alphabetically. Anyone whose surname fell before K and after K would be on the different teams. I can't actually remember which one I was on, but it was busy. So we'd have about 15 patients each, and the interesting thing about psychiatry is that the ward rounds went forever. I think it's really important to realize that psychiatry is super subjective. Other rotations are very objective. So if you've got a broken bone, we can tell once you're able to do X, Y, and Z and have the cast on for, Y number of weeks, then you're good to go. Psychiatry is not like that. It's not, today you score a 10 out of 10 on happiness scale, out you go. It's, what are your risks? What is your follow-up? Do you have a follow-up? Do you have a GP, a psychologist, family? If none of that, or only some of it's in place, sometimes being in the ward is the safest thing for you. So it was a very subjective rotation to be on, which made it very different. Also because of this, our ward rounds sometimes would go for hours, if not whole days. If we had 15 people per round and the average interview time was about an hour, you can see what I mean. Of course, not everyone required the full hour with the team, but some did. And it's because we had to build that rapport. We had to get to know you, know why you were so unwell, what we were doing, was it helping, was it not, and what were we aiming for. Obviously, some disorders had a very clear-cut discharge goal, I suppose. For example, if you were there on a manic episode, once we were able to neutralize that and make you not manic anymore, that was a lot easier than, say, someone who was chronically depressed, suicidal, schizophrenic with, hallucinations or paranoid ideation that wasn't responding to therapy, that sort of thing. Really, really complex. And it's also a very hard thing to talk about without coming across as judgmental or using the wrong nomenclature. Mental health, there's a big stigma around it. Everyone knows that, and everyone's very gung-ho about let's break it, but it's still really, really, really hard. And it makes it a bit hard to talk about. But please know that I'm coming from a really good place. So if I say anything that could be construed as incorrect politically or rude or condescending, please know that that's not my intention at all. Okay, that bit of a tangent aside, let me get back to my experience. So we would have the 2 teams, and in that team we'd all have a consultant, a registrar, and then a junior health officer and or an intern, sometimes just the one, sometimes both, sometimes 2 interns, and sometimes 2 JHOs. So it was kind of a mixed bag. So what was the rotation actually like? Well, not that different to begin with. What I mean by that is I would still get there early, do up a handover sheet, getting information from the night team about what had occurred overnight, then I'd go to handover. The handover would be for everyone, so not just your own team, but then you would split off and do your own ward round, basically. Because we had so many patients and because some of them would take quite some time, what we would often do is split the ward round. So the junior staff would often get the less acute people or the ones that are getting really close to discharge, and we would go and see them. So I would sometimes run a part of a ward round by myself, which was fun and also scary. The registrar and the consultant would often split up as well, and the consultant would see the very high risk patients, or at least start to see them, whilst the registrar would see the moderately risky patients. And by risky, of course, I'm talking about those who are at high risk of suicide or who weren't responding to therapy. It's very hard to describe, so I'm doing the best I can. If the ward round did eventually end, and sometimes it wouldn't, we would then do a lot of paperwork. So out of every rotation I've ever done, this was the most paperwork intense rotation by far. Sometimes you just forget that there was a world outside the paper. Not only did our ward round notes need to be really, really detailed, but our discharge notes did too. So it wasn't just so-and-so was feeling like this. We also had to put what we were visualizing into it by doing a mental state exam and a couple of other side things. So what did they look like? Were they well groomed? Did they keep eye contact? What was their speech like? Were they pressured, as in pressure of speech, like they couldn't stop talking? Did they dress appropriately? Did they, as in for weather, did they look like they were listening to something that wasn't in the room or looking at something that wasn't in the room? A lot of things go into it. What were they saying they felt like? You know, did they say they were happy but they were sitting there sobbing? Was there a congruency? You can see why notes would take some time. And coordinating discharge care took a lot too. So we had social workers, we had occupational therapists, we had physiotherapists, the whole shebang, and we would be nothing without our team. But the aim, of course, was to discharge someone into the community where they could continue to live their lives and not let their mental health issues or their diagnoses rule their lives. So the highlights of the rotation, it's really hard to say. I think seeing some people discharge when you'd seen them in the inpatient ward for so long was so rewarding. But also the privilege of hearing the stories was a highlight. So you would hear some horrific things, just absolutely horrific. But the thing is, someone opened up to you and told you. And yes, I appreciate that there was sort of a sense of needing to talk about it, but they still consented and they still wanted to talk to me about it. And so I'm really privileged and really, really thankful that I was able to hear those, and it's helped me grow as a practitioner. You can imagine the lowlights, of course, are hearing the stories, a bit ironic there. But God, there are some horrific things that happen in the world. The paperwork was also a big bummer, huge bummer actually. And just the politics of it all. Just the deadlines on certain things, as I'm sure you're aware or might be aware of, you can be put in under an order or involuntarily into the mental health ward, and there are very strict things that have to be put in place for obvious reasons, and doing that paperwork sucks, but it's very, very much needed. So I get it. I'll complain, but I also understand that I shouldn't. If I had to give anyone any tips about the rotation, it would be look after your own mental health during it. Make sure you have your own GP, and if you're someone who's predisposed to mental health problems, get your own psychologist. It can be very confronting, very, very confronting to hear. I was very, very lucky that my consultant was amazing and every week would debrief with us and basically give us therapy. It was awesome. But again, general things apply. Be organised. Have good resources. So the DSM-5 is fantastic. You don't have to know it back to front, but just to understand why we do some of the things we do, you need to understand what the disorders are. So why do we do certain therapies for depression but not anxiety or schizophrenia? understanding the disorder and why we diagnose someone with that can be very helpful. Alright, and now for the diary entries. I, for some reason, didn't write too much around this time, but that's okay. I think even if I did, it's very hard to keep confidentiality, because a lot of my thoughts and what I would have journaled about would have been about specific cases, and obviously I won't be telling their stories online, that's not my role. But I do have some, so here we are. Alright, so this one is dated the 2nd of December 2018. Mental health is a tiring term. I love working with my team, but I feel mentally exhausted some days. It's all of the counter-transference and transference for sure, but still, I'm 3 weeks in, and I've only now felt like I've figured out what my job is, kind of. I struggle the most with patients with borderline personality disorder and the drug users because I just don't understand them, but I'm trying. I feel like I'd love to see a psychiatrist sometimes, not because I'm floridly depressed or anything like that, but because I love how analytical they are, and I can see how a lot of things would line up. I really like to analyse and to introspectively review myself. Anyway, it's all interesting for sure, but it's 2 AM and it's bedtime. This one is actually the last journal entry I did in 2018, which was a 2018 recap. So the 30th of December 2018. I started psychiatry this month and I adore it. However, psych is yet another specialty I will never ever pursue, but I'm thankful that I'm having this experience. I had Christmas in the mental health ward and it wasn't as sad as I thought it was. It's been a busy, great and emotional and anxious term, but I've loved it. And then I didn't run again to February, which was when I started my GP training. So there you have it, guys, and that is the Rotation Diaries wrapped up. I may come in and do a sneaky bonus GP Rotation Diaries entry, but it's a little bit different because it's kind of my career and not just like a 10-week feel. But let me know if you'd be interested. And again, I've done like the big series that I was planning to do. I have a few ideas. Actually, I have a lot of ideas, but I'd love to know what you want to hear from me. As of today, August the 16th, 2020, I have 20 subscribers and I'm absolutely over the moon about it. I didn't think I'd get this many. So for the 20 of you that watch, let me know what you want from me. Otherwise, guys, until next time, stay safe, stay healthy, and I'll see you in the next one. Who knows what it'll be.